Dystrophism, a very deadly sight for parents. If you have seen the kids, how they born with the deformities, to enlighten us what can be done for such disease, we have an eminent neurosurgeon from Dr. Ajay Bajaj, and I request Dr. Nilesh Jhope and Dr. Aparna Pawar to please accompany Dr. Bajaj to the stage, please. Dr. Nilesh Jhope is a spine surgeon and he's having his own orthopedic hospital in Dombivli East. Dr. Aparna Pawar is a dermatologist with her clinic on Phadke Road, Dombivli East. Now I request Dr. Aparna to please introduce our speaker. Thank you.
A very good morning to all. I take this opportunity to introduce our eminent speaker, Dr. Ajay Bajaj. Dr. Ajay Bajaj is MBBS from King George Medical College, Lucknow. He has done his general surgery, MS in general surgery from IMS BHU Varanasi and MCH neurosurgery from PG IMER Chandigarh. Sir is the senior consultant neurosurgeon in Fortis Hospital, Mulund. In India, there are less than 50 neurosurgeons who can perform aneurysm clipping, and Dr. Bajaj is one of them. Sir has special interest in pediatric neurosurgeries and has performed over 500, of which 75% surgeries were complex cases. He is an active international member of Congress of Neurological Surgeons USA. Sir has participated in crash trial conducted by Medical Research Council, London. He has delivered a guest lecture on pediatric neurosurgical problem in first Ethiopian Neurosurgical Conference. I am very pleased to welcome Dr. Ajay Bajaj to deliver his talk on spinal dystrophic state.
Spinal dystrophism basically is a very complex topic, and previously the incidence was very high because of the non-availability of high quality ultrasonography and a good antenatal care. The incidence was very high, but nowadays the incidence of these type of congenital anomaly of the spinal cord and the brain is like the neural tube defect is now is still present, but it's rare because of the development of high quality ultrasound and maternal care and good nutrition, folic acid supplementations. So if we see the spinal dystrophism basically is a state in which our spine is split into two parts, and in this part the various component of the spinal cord or a neural tissue come out from that defect into the external circulation and lead to a various type of malformations of the spine and spinal cords. So some malformations are non-viable and some are viable. Like there are certain type of malformation in which there is a complete non-formation of the brain and the skull, which is non-viable. So there are type of anencephaly in which the tissue is or fetus is unviable, but there are certain type of malformations like a simple meningocele in which only the meninges came out from the defect and causes a swelling into the system outside. This is viable, and patient, if you operate timely, the patient goes well even without any neurological deficits. So if we see the spinal dystrophism, basically slide up down. So if we see spinal dystrophism, it is divided into basically of two parts. One is the open type of a spinal dystrophic state, and another is you can see this all type of kits where, which I discussed, cranioschisis, anencephaly, encephalocele, spina bifida occulta, closed and open spinal dystrophism. If we see, these are the various cases which I have operated, a type of dystrophic states in various locations, maybe dorsal, cervical, dorsolumbar, various type of area. This is occipital. You can see a large defect inside the skull. So, if we see, it is divided into two parts: open spinal dystrophic state and closed spinal dystrophic state. So, what is the meaning? Because sometimes when we were studying MBBS, we are confused: what is open, what is closed, what is cystica, what is aperta. So, this is basically of two types. Open means when the neural placard or any neural tissue is exposed to external environment. So, like external environment, then it is called a open neural tube defect. When the defect is, so in that case what is happening, the whole of the contents like a nerve tissue or everything is exposed to environment, then the chances of meningitis and encephalitis is very, very high. So in such cases, the aim of the treatment is to close the defect as early as possible to prevent the meningitis. Then the second group is the closed spinal neural tube defect. In that cases, the defect is covered with skin. So the chances of infection is less, and then this closed defect can be of two types: with subcutaneous, something you can feel some mass, or without subcutaneous mass. So in subcutaneous mass, you can have a meningocele, meningomyelocele, or lipoma. Or in closed spinal dystrophism, there is no defect seen or nothing is seen on the back, but still patient is going to have some sort of spinal dystrophic state. In that cases, it is very important to diagnose such patients, because in that cases clinically outside you can see only sometimes the tuft of hair, or sometimes you see a small dimple or a small sinus tract lying outside. So these defect, these type of cutaneous stigma indicate that that patient can have some sort of spinal dystrophic state or some sort of tethered cord inside the spine, and these patients should be evaluated clinically. I am giving you one example of a lady. So she was around 32 years and came to a gynecologist. She had her first pregnancies, and for which they were planning for a cesarean section under spinal anesthesia. So that lady complained of some perianal sensory loss or some urinary incontinence. So they told me to have a neuro opinion. So the patient came to me, and I examined that her foot was like claw foot was there. It was a foot deformity. And when I examined, she has a perianal sensory loss. So I did an MRI, and that shows the spinal cord was tethered and lower level of the cord was at L4, L5. In that case, by chance, if she got spinal anesthesia, then the chances of paraplegia is very, very high. So we told to the anesthetist, this time you go cesarean section under general anesthesia. It was delivered, and then later on we do a detethering of the cords. So whenever any lady with a pregnancy came with you and have some neurological problem, we should always think of some sort of to rule out some spinal deformity. And while giving spinal anesthesia, it is our duty to check, because sometimes these defects are unnoticed. Sometimes they are asymptomatic. You don't find any neurological deficit. So when you check on the back before giving a spinal needle, you check whether there is any dimple or tufts of hair is present. Then stop it and then see whether they have any deformity or not. Next, please. Next slide. So in open type of a spinal dystrophism, we can have a meningomyelocele, myeloschisis, hemimyelocele. Myeloschisis means the whole of the skin is absent, dorsal part of all the tissues are absent, and the spinal cord is split open to the external environment. This is not covered with the skin defect. Neural placard is exposed to external environment. Chances of CSF leak and meningitis are very high. So repair should be done as early as possible in open type of dystrophism. And extent and severity of neurological defect definitely depends upon the location of the this dystrophic state, whether the meningomyelocele is at lumbosacral area, lumbar area, sacral area, dorsal or cervical area. Higher the level of the defect, the chances of prognosis is very bad. Next, please. This is, you can see the majority of these meningomyelocele defects are usually associated with Arnold-Chiari malformation and hydrocephalus. So these patients should have an MRI brain to look out associated hydrocephalus or Arnold-Chiari malformation. Next, please. So in closed variety, you can have a with subcutaneous mass lipomyelomeningocele or simply meningocele, or without, you can have a various forms of complex dystrophic state, which is important to diagnose, like a split cord malformation, tight phylum terminal, phylum or interluminal lipoma, or a dermal sinus. So in occult dystrophism, the overlying skin is intact, but spinal cord is anchored at various level with the skin or subcutaneous tissue or adipose tissue or cartilage. Next, please. So you can see in meningocele, simply the meninges came out through the defect, and which is very simple, and the chances of neurological deficits are almost nil. In meningomyelocele, a part of neural tissue is coming inside the sac. Next, please. So there is something called what is the tethered spinal cord. So tethered spinal cord comprises of a group of dystrophic state in which the conus medullaris, lower part of the cord, is lying at a lower level. Previously, we were thinking that there is a cord ascent, like at the birth, we thought that the cord is at lower level and slowly it progresses to the upper level. But normally, even there was one study in which they did a neonatal MRI, which shows the lower cord of the cord is at the level of D12L1. So if any level it is below D12L1, then it is supposed to be a tethered cord. Next, please. So what is next? So you can see a conus medullaris as D12L1. If the cord is lying at the lower level, then it is supposed to be a tethered cord. Next, please. So what is tethered cord? The symptoms which may lead to, because of the tethering of the cord, is a tethered cord syndrome. So sometimes the cord is tethered at the lower level, but there is a stretch effect even at cervical level or at dorsal level, giving rise to various type of myelopathic symptoms. Next, please. So what is the problem? So these tethered cord in due course of time can give rise to neurological symptoms like paraparesis, quadriparesis, sensory symptoms with bladder and bowel involvement. Next. If we repair, what are the problems once we repair meningomyelocele? How these patients are like in follow-up? If we repair meningomyelocele, then 10 to 30% children will develop in future the symptomatic tethered cord syndromes. And precise follow-up of these children are necessary. Next, please. Because if we deal these tethered symptoms early, then the neurological recovery is better in these patients. Next, please. So how these tethered cord symptoms patients present to us? Next. They present with, next please, motor dysfunctions, like they can have a weakness in the both lower limb or upper limb. They can have back pain or leg pain or bladder dysfunction. Next. So this is the type of foot deformity, sensory deformity. This is an interesting case. On that side, you can see both the toes are absent. So this is a son of a tea seller. So he had an injury to the left toe, which was like broken from the foot, and he don't have any pain. So nobody knows, neither the mother or father knows that he had lost one toe. After some time, he had lost the second toe of the other limb, and once her mother was like giving him bath, so she noticed that both the toes are absent. So they told to consult a doctor. So they came to us. I find a sensory deficit, but there was on the backside, nothing was there. So MRI was done, which shows a thickened phylum terminal with low-lying tethered cord. So detethering of the cord was done, and then patient improves slowly. Next, please. So orthopedic deformities are present in approximately 90% of such patients. Next. And cutaneous anomaly are present in approximately 70% of the patients. So what type of cutaneous anomaly is seen in this type of occult spinal dystrophism? Next, please. You can see various type of hypertrichosis, dimple, or a small lump, or sometimes like cutaneous, this is known as cigarette burn. The meningocele is shrunken, atrophic, chronically such type of lesion you can see in tethered cord. Next. In MRI imaging is important because it shows level of the cord, whether what is the anomaly which is residing inside the spinal canal. Sometimes you can see a thickened phylum terminal. Next. So what is the challenge in such patients? What is the aim of the treatment? In case of an open neural tube defect, the aim is prevention of meningitis in such patient, and closure should be done as early as possible. Next, in closed spinal dystrophism, the aim is to improve or stabilize deficit in symptomatic patient and to prevent future deficit in asymptomatic patient. Next. So this is, you can see various type of a lipoma of the cord in which complete excision was done and patient improves. Next. So the treatment, if we see etiology in such cases is multifactorial. There are some genetic causes which can lead to such type of defect. There are some environmental factors, mainly the maternal nutrition, folic acid supplementation is important because reduced level of folic acid in the first trimester of pregnancy can lead to such type of defect. Next. Next, please. So ultrasonography is important, and maternal serum alpha fetoprotein levels. These are two important markers, and it should be performed at 12, 22, and 32 weeks of gestation. Maternal serum screening can detect up to 80% of the cases of spina bifida and 90% cases of anencephaly, which can be detected early. And sonography can detect up to 90% cases of myelomeningocele cases. Next, please. So total number of patients I operated around 114, out of which 110 were pediatric and 4 cases came in adult, and out of which 12 were purely meningocele, 30 were meningomyelocele, and various type, 60 patients have various type of thickened phylum terminal, lipoma of the spinal cord, lipomyelomeningocele. Next. So in such patients, management is basically multidisciplinary because sometimes these patients have associated other defect like anorectal malformation or vesicle anomaly or defect of the bony defects, cardiac defects. So the approach is multifactorial, and if diagnosed early, it can be either prevented or can be treated at an appropriate time. Thank you. Any question?
Hello. Thank you, Dr. Bajaj. Actually, this is a very complex topic. You rightly pointed out that good clinical examination is very important. Second thing, this is multidisciplinary approach. We need to involve neurosurgeon, orthopedician, plastic surgeon, urologist, and finally physiotherapist. Combination of all this highly specialized doctor can improve life of this patient. Thank you. I invite any question from audience.
Thank you.
Thank you.
Thank you, sir, for a wonderful lecture on such a difficult topic. I request Dr. Nilesh Zope to please felicitate the speaker. I request Dr. Deepa Shukla Madam to felicitate the chairperson and moderator. We thank Fortis Hospital Mulund for being associated with us for this lecture. Cancer is a deadly word, as it not only causes death but a lot of morbidity as well. Now, to talk about such a morbid and deadly cancer, colorectal cancer, we have a leading oncosurgeon and wonderful orator, Dr. Anil Herur sir, with us. I request Dr. Dhaktode Madam, who will be chairing the session, and moderator Dr. Hamberde Madam to please accompany sir to the stage.
Dr. Anil Herur does not need any introduction. We all know him very well. He is head of surgical oncology unit at Fortis Hospital, Mulund. He has completed MBBS from St. G.S. Medical College, MS General Surgery from LTMG Sion Hospital. After that, he has done his surgical oncology training at Tata Memorial Hospital. He has numerous publications, including 17 international publications. He has received many awards and scholarships, including Best Paper Award at 2 international conferences. He has done training and fellowships in Memorial Sloan Kettering Cancer Center in New York, Japan, and South Korea. His areas of interest are thoracic surgery, CA breast surgery, esophageal surgery, and laparoscopic minimal access surgery. His surgical oncology unit at Fortis Hospital, Mulund does about 500 cases every year. And he has, they train young surgeons in minimal access oncosurgery. Last year, Maharashtra University of Health Sciences approved fellowship program for colorectal surgery under his guidance at Fortis Hospital, Mulund. He conducts regular CMEs and active faculty at numerous conferences. He is active in social causes, having organized numerous awareness programs in schools, senior citizen clubs, and society. Recently, he has organized Cancer Awareness Walk in Dombivli on 22nd February 2015. He awarded Best Doctor of the Year by IMA Dombivli in 2016, Adarsh Dombivlikar Award in 2017. He also has his own units in Thana, Dombivli, and Mulund.
Thank you, Doc. Thank you, Dr. Hamberde, and that was very kind of you. It is always nice to be among family and friends, and this is one of the most enjoyable IMA talks that I have always. I stand between you and lunch, and unlike the Maharashtra government, I will not keep you waiting. So that's an assurance. So today I will be speaking on one of my favorite topics, which is colorectal cancer. Cancer of the colon and rectum, if you remember, a lot of seniors sitting in the audience, was not something that was on our radar even a decade ago. It was a diagnosis that happened, but did not happen very commonly. But now we are seeing it happen more and more frequently. And if you look at it globally, then there are more than about 1.5 lakh cases which are diagnosed every year. If you see, the incidence of colorectal cancer as such is rising. And though you may see the worm of India, which is sitting right at the bottom, you will see 2 prominent worms, and this is something that I always allude to in my talks on colorectal cancer, is that there are these 2 worms which are there. This is the one which is of Japan, and this is the one which is of Korea. And these are steep worms, and if you see, in a matter of about 2 to 3 decades, the incidence of colorectal cancer almost doubled, and even more. And if you actually analyze these situations, these countries during these periods, like for example, Japan between the 70s and the 90s, went through a period of extreme social transformation. It went from being a rural agrarian economy to becoming a very industrialized modern society. Cultural habits changed, food habits changed, and ditto in Korea. So now if you see India, what is happening? So about a decade ago, Dr. Mohandas had presented a paper on what was the incidence of colorectal cancer in India. And that time, the number of cases were approximately about 25,000 cases, which is about an incidence of 2 per 1 lakh in colon and about 3 to 4 per 1 lakh in rectum. What is the situation in 2011? Now that is the latest census that we have. In 2011, you have these cases which have increased from 25,000 to almost 75,000, 70,000 plus. So if we are we don't know whether we are progressing as far as Japan and Korea are concerned, whether we are progressing at the same pace, but definitely in cancer, we are definitely doing much better than the economy. So we are growing much faster in cancer than what our economy is growing. So that is that steep curve that you see is now being replicated in both in India as well. The more worrying thing about colorectal cancer is this. If you see, this is now by my friend Avnish Saklani from Tata Memorial Hospital. So they went through the patient. Now if you see the patients coming to Tata Memorial essentially mean that they are a sort of a microcosm of what the subcontinent is. Not only India, but the subcontinent is. So they had about 1,000 patients who are coming to them in a year. And if you analyze, they analyze the age groups. And this is the worrying part of the demographics. See, 20 to 60 make up about 75% patients of colorectal cancer. And that is where our worry lies, because this is your productive age group. And if they are going to be afflicted by a non-communicable disease which is chronic, then you certainly have a problem on your hands as a society. Forget as a patient, as a family, as a society and as a nation, you definitely have problems on your hands if you 75% of your patients are going to be between the age of 20 and 60. So what happens? So how does it happen? Basically, we all know, we have all gone through Robbins of pathology, and certainly me as a parent, I hear these words because one of my kids is in 2nd MBBS, the other is in 3rd MBBS. Right now they are writing their exams. So I hear these words often. So if somebody asks me about pathology, I can give an answer, and people are surprised. So they don't know that my sons are now teaching me. So basically, this is the polyp adenoma carcinoma sequence, which we all know. Now, if an early diagnosis is not done, then there are a lot of genetic changes that happen within the mucosa, which lead to a transformation of a normal benign polyp into cancer. And that is where our, and there is a lot of opportunity that lies between these two, between these sequences, and that is where our opportunity lies to cure this cancer if caught early. What is the etiology? What are the risk factors? One is age. As the age increases, definitely the incidence of cancer increases. Polyps of the colon, hereditary, smoking, physical inactivity, too little fiber in diet, too much of red meat, obesity, and high fat foods. So if you see, most of the risk factors are actually lifestyle related. Another something that as general physicians, as people who work in the community, we have to keep it in mind that this is an opportunity for prevention. There are other factors as well. Inflammatory bowel disease. Now, I'm sure you will agree with me that we are now seeing a lot more inflammatory bowel disease. Diverticulitis was something which was unheard of in India. Now we are seeing patients with diverticulitis. We are seeing more patients with Crohn's. So this is a reflection of the burgers and the pizzas that our kids are eating, and definitely this is going to become more and more common. Environmental factors are there, alcohol consumption, all these factors go ahead and cause malignancy of the colon. Diet and cancer is something which is always been debatable. There was this large trial in Europe called as the EPIC trial, which actually had an epidemiological study which studied what is the relationship between diet and cancer in general and colorectal digestive cancers in particular. The data on red meat was quite clear. Definitely there is a relationship, there is a direct relationship between incidence and consumption of red meat. Somebody went ahead and actually analyzed what actually happens in red meat. So this is something that when patients ask us, we have to know that it is not just the red meat, it is the way it is cooked. The more barbecued it is, the more changes that happen at the protein level, the more chances of it causing malignancy. So this is something that has been extensively studied. So if you see, this is the kind of lifestyle our kids lead, sedentary lifestyle with a pizza, with a burger, with red meat, with video games, and this is where our future risk of colorectal cancer rises. And this is, I'm sorry that it's not very clear, but this is how it has been studied, that it increases inflammation, and decreases apoptosis. And this is what causes cancer proliferation as far as food and inactivity is concerned. Hereditary colorectal cancer is a very small part of colorectal cancer incidence. It is hardly about 20%, but it attracts a lot of attention, and definitely there are now more and more tests that are coming in order to know what is the relationship between familial cancer and family history and incidence of colorectal cancer. So this is the general thing which has been studied in the US population. That is, if you have one first degree relative with colorectal cancer, then it is a 2 to 3-fold increase. If there are 2 relatives, then it increases 3 to 4 times. If it is one person who's less than 50 years of age, then again it is 3 to 4 times. If it is one second or third degree relative, then it is 1.5 times. If it is 2 second or third degree, then it is 2 to 3 times more than the general population. This is the way the risk is. If you have somebody, if some patient is going to come to you and say that my grandfather has colorectal cancer, what is my risk? Then this is what you can tell him. We all know the symptoms. The symptoms basically depend on whether it is a left-sided cancer or a right-sided cancer. The most important take-home message as far as what I want to give this audience is, please do not take anemia very, very lightly. Normally, we think of anemia as something very benign. We do not investigate it. Neither do patients like it. Nustas hemoglobin kami hai, tumhi evde saghe test sangta. If they are not responding to your routine treatment, please do at least a stool for occult blood in the proper way, because anemia is the only symptom for a right-sided colonic cancer in its early stages. You will not have anything else, and that is where the misdiagnosis lies. That is where the window of opportunity is lost. As far as the left-sided cancers are concerned, especially rectal cancer, even in young males, let us not label everything as piles. A lot of them at least do have a malignancy which is lurking above what looks like piles. So bleeding PR in cancer is usually minimal. It occurs at the end of defecation. So again, there is a differentiator as far as clinical history is concerned when there is between piles and cancer. So the cancer of malignancy is usually at the end. It is mixed with stools, is noticed because it stains under clothing, and sometimes, you know, it gets labeled as internal piles, and that is why again the diagnosis is missed. Patients have tenesmus, they have alteration in bowel habits, there is early morning bloody diarrhea, and somewhere in 1 out of 5 patients there may be a family history. There is no other sign. There is no other sign. These are things which come up very, very slowly. You will rarely get a patient with ascites and liver enlargement and hemoglobin of 2 or 3 which is causing symptoms. Though recently I had a patient who presented with a hemoglobin of 3. After a long, long time, after Sion Hospital, I have seen a hemoglobin of 3. And the person had actually a gastric malignancy. But he came, he was actually falling down and he had to be supported. And this is something that we used to see in obstetrics and gynecology and very rarely in surgery. But this, after a long time, I saw somebody with an hemoglobin of 3. So again, this is something that has to be mentioned whenever we talk about rectal cancer, that if you don't put your finger in the rectum, you're going to put a foot into it. And this is Bailey Love, very basic and beautiful book, and which always emphasizes on the right clinical signs. So what do you do next? Next is a colonoscopy. I think the threshold for doing a colonoscopy in cases of anemia and bleeding which do not respond to standard treatment should be very low. I know it's a very discomforting procedure. It is not something that patients like, but it is life-saving. And definitely today, our hematologist actually, one of the investigations he does in anemia workup is a scopy. Because he says, and the number of patients that have been getting diagnosed are really, really very high. Because this is a cancer which is now increasing in incidence, and definitely we have to be very, very alert as far as the symptoms are concerned. So these are very subtle symptoms, but they are symptoms not to be missed. What are the other investigations? CEA is a tumor marker. Again, no tumor marker diagnoses cancer. So let us not be under the impression that the CA एक होता त्यामुळे कॅन्सर होता की नाही कसं कळणार. The CA will not diagnose colorectal cancer. CA is a prognostic marker. It is used for monitoring the progress of the disease and not for diagnosing it. A CT is done in right-sided cancers. In the rectum, we normally now prefer an MRI. Though even if a CT is done, the oncosurgeon or the oncologist may still ask for an MRI because that is what is used for staging after treatment. PET CT again is very, very rare. This is how the cancers are now staged. We have moved from the Astor Collins to a proper TNM, tumor, node and metastasis kind of classification. Surgery, again, they are major surgeries. In rectal cancer now, there is evidence that somebody who is trained to do the job or who does more than 12 rectal cancer surgeries a year is probably someone whom the patient should get operated with because that has an effect on prognosis. Laparoscopic surgery, as I always keep repeating, is something that has revolutionized or changed colorectal cancer surgery completely. Now adding to it is something which is again new, is robotic surgery. I think Dr. Maheshwari must have spoken a bit about robotic surgery. We at Fortis now have the XI robotic system. Honestly speaking, it has really opened a new vista and something that we never imagined could be done with minimal access. It has brought first thing that a surgeon realizes when he handles the robo is the vision. And the vision is beautiful. It has depth, it has magnification, and for the first time I felt like I was getting a vision as good as a wife, though I have not told her that my vision is as good as you. I wouldn't do that. So, but that is how things look. The depth is beautiful, the colors are vibrant, and you actually feel as if you are seeing something with the naked eye and real colors. So that is something that hits you first. The second thing that you like in a robo is the wrist, is the movement, is the freedom that you get to move the instrument like a wrist. In fact, more than a wrist because it has 7 degrees. Your wrist can move around 270. The robotic arm can actually go 360. So it's like the Exorcist movie. You can actually move your wrist 360 degrees. So you can operate like this, which is something that you can never do as in open surgery. The movements are, there is motion scaling which occurs. So when you move it one time, then actually the robo moves, can move 5 times. So sometimes it gets a little getting used to, but once you are used to it, it is wonderful. Now, can I have the videos, please? So this is the way, I have just arranged a medley. So all the 4 ways of, the ways of skinning a cat, as they say, there are multiple ways of skinning a cat. So here you will see open surgery. It is the same step. It is a rectal cancer patient. We are taking the inferior mesenteric artery. These are 2 laparoscopic ways of doing it. That's robotic and that's open. So you will actually appreciate the change in vision that happens. You see the robo gives a depth. The robo can turn. It acts exactly like my mixture that is there in open surgery. And the vision is much better. The laparoscopic instruments give the same vision almost, but they do not have the dexterity that the robo has. So this is the way the surgery has changed. Here you are seeing from a distance. Can you play them again, please? Can you play them again? Can you play them again, please? जेवायला वेळ आहे रे राजा, भूक लागली. So you can see that in the open technique, you are operating at a distance. In the robotic or in the minimal access, you are actually going down, reaching out, and then operating. And that is the way, that is the beauty of what robotics brings to the table. These are energy sources which have come. What you are seeing in the laparoscopic videos is the energy sources that are being used. So we have moved from the OT today is more like a, what do you say, it has become like an electronic display room. You have so many machines that are there in the OT that you begin to wonder whether it is Vijay Sales showroom or whether it is an operating theater. But that is how it is. So we use routinely words like 4K. So madam, we something which we never used to think that this will happen in surgery. But that is that's the change that has happened in the last 10 years. Another thing that has happened is basically reach. Minimal access gives reach. This is deep pelvis. Again, this is the lower part of the rectum, and this is the stapler which is coming in. So a lot of patients who used to end up with a permanent colostomy now have been able to save their sphincters. In fact, with robotics, the depth perception is so good that you can actually go up to the levator ani muscles, which is the floor of the pelvis, dissect out the rectum and do what is called as a coloanal anastomosis. You could do it minimal access as well. You could do it laparoscopically as well, but robo makes life much more easier. What is the disadvantage of robotics? The disadvantage is only one and only one, that is the cost. The cost is a big stumbling block as far as robotics is concerned. The machine is horribly expensive, and hence some of the cost definitely gets transferred on to the surgery. The surgeon, the hospital and the patient, none of them really are happy with the cost, but finally it's a technology which personally I feel whose time has come. Hence, in spite of having such huge costs, today the procedures, robotic procedures in India have increased from being about 1,000 in 2010 to nearly now 7,000 to 8,000 today. The number of robotic installations in India have increased up to 70 installations, something that we had never thought of. All the AIIMS hospitals, all AIIMS, All India Institute of Medical Sciences, including AIIMS Rishikesh. Now, one of my students now is in AIIMS Patna, and he told me they are getting a robo in four months. So all of them have started getting robotics. So somewhere down the line, it is like mobile phones. When mobile started, we used to pay 16 rupees per call. Everybody thought that this will never survive. But today, we are now at a point where we can talk continuously without even paying a rupee. Of course, that will change again. We all know that, because otherwise Vodafone and anyways Vodafone is closing down. So this is the way the technology will progress. My opinion, and I frankly told the company that if this technology had a better father, then by now it would have replaced laparoscopy. Just 2 minutes more. So from incisions which were huge, grotesque, we are now coming down to very small incisions. That is one of our patients with a right hemicolectomy, that is a rectal cancer patient. And this is where probably the march will be. Now more than 80% patients go with minimal access surgery in our unit. Radiation also has kept up pace. Radiation now plays a big role in colorectal cancer surgery, especially in rectal cancer surgery. Lot of patients, most patients rather, 90% patients would get radiation before surgery. It helps in two ways. It improves survival, and it improves to save their sphincter, so they don't end up with a permanent colostomy. Genomics and targeted chemotherapy. Somebody speaking on immunotherapy in the afternoon. So you will know a lot more about immunotherapy when you hear that lecture. But this is again something that has completely changed the way we look at cancer treatment. We now have personalized cancer treatment. There are labs which now do precision medicine, which tell you that this person has this tumor which will respond to this kind of chemotherapy. So we are now going into an era where we will have each individual patient knowing his or her prescription for chemotherapy. So this is how we have to screen patients. So if it is a category 1 risk, then we do a stool for occult blood examination. If you have high risk patients with a strong family history, then there is something that then they will read more regular screening with colonoscopy. Thank you very much for giving me this opportunity. Any questions? I would.
Thank you, Dr. Anil. In the audience, anybody would like to ask questions? Yes. Can we have a mic to Dr. Anil here, please?
Thank you. What is the ideal way of doing the stool examination to know whether occult blood is there?
So the stool examination now has 2 ways of doing it. One is something which we used to do it regularly, that is the GUAC test. In that, we have to instruct our patients to take 3 consecutive samples. At least for 72 hours before that, they have to be off any kind of iron preparation, avoid any kind of meat products, anything that contains heme, because basically, as we know from our biochemistry days, what the test does is basically check whether there is iron. So it does not check whether there is any blood. So it checks iron, so they have to be off that for at least 72 hours. I think so that is the thing that precaution has to be taken. The second is immunochemical test that is also now available, though it is not used clinically since it's a very expensive test. That checks about human DNA which is there in stools. That is much more accurate.
Thank you, sir.
Can we have
Yes.
the mic to Dr. Hamberde, please? Sir, please wait. Sir, we are giving you the mic.
Should all the patients of bleeding piles or any bleeding PR should undergo colonoscopy?
So there are a lot of surgeons now. So to be very honest, personally, I do feel that all patients of bleeding piles should undergo at least a sigmoidoscopy, not a full colonoscopy, at least a sigmoidoscopy. Annually, we have at least one patient who has been operated for piles. And then has something which is bleeding from top. So personally, I would recommend, there are no recommendations that you should do colonoscopy in all piles. But I think once you face something like that, everybody starts doing a colonoscopy.
Yes, sure.
Dr. Herur, I had one question. Is the insurance company covering the robotic surgeries?
A very, very interesting question. So, luckily we have had, last month, we had a ruling from IRDA saying that there is a certain procedures which will be covered. So, lasers was one. Robotics is also something that they have said. Now, we have had very interesting, experiences with insurance companies. We had two brothers from Ulhasnagar. One of them was a doctor, in fact. He had a mediclaim from Future generally, and his brother had a mediclaim from some other company. So the Future company agreed to give the robotic part of the mediclaim. The other company did not. No reasons were given. The second time after the IRDA ruling, we presented the IRDA thing to the insurance company, and then we managed to get the insurance covered. So insurance companies are quite ambivalent on that. If you push them, they will. If you don't, then they will not. So it is something which is negotiable sort of as of now. The second thing is, when you say robotic surgery, they do cover the laparoscopic part. They may not cover the robotic part.
Thank you, Dr. Herur. Dr. Herur has very nicely enlightened us about the colorectal cancer, how there is a rise in percentage in the younger age group, and stressed on the early diagnosis. It is very interesting to know how robotic surgery is helping us for the good depth vision and avoiding permanent end colostomy. So I would like to thank him for his very explicit lecture. Thank you, Doctor.
Thank you, sir, for a wonderful lecture as always. Now I request Dr. Dhaktode Madam to please felicitate our speaker. I request Dr. Kamath Madam to please felicitate our chairperson and moderator. Thank you. Are available at the first floor near the lift. Please make use of it. And I really thank you, Mulund Fortis, for being associated with us. Thank you.
That concludes our pre-lunch session. We had some very interesting topics discussed today. And Dr. Hemant Patil conducted the session very smoothly. We really thank Dr. Hemant Patil for this, and I request Dr. Niti Upasni to felicitate our MOC for the morning, Dr. Hemant Patil.
Tuesday, Friday.